for those of us who aren't here. All right, good morning. This is Dr. Garais, and this is Med140 Basic Clinical Procedures. And the public service announcements today are twofold. One, go into your announcements. Make sure that you look at this laboratory schedule and look for your laboratory dates. For Med140 8DAX, there's 2 sessions. And if you cannot make those dates, I need to know about it like as soon as possible, because we have to adhere to the CDC guidelines, and I have to make sure that there are not too many people on campus at any given time on the 4th floor. And I have to also coordinate with the School of Nursing and also the School of Culinary Baking and Pastry. So if you don't get to me, you may not be allowed on campus, okay, if there's too many people, all right? Even though the data is suggesting that COVID is diminishing within the area, which it is. But again, it's a virus. It's a virus with no vaccine. It's a virus with no cure. And if you have any high-risk individuals in your family, or if you're a high-risk individual, especially one who's had a lot of lower respiratory tract infections, I am one of those people. Also, I am no spring chicken, so I am at risk. So I want to reduce the risk for myself and for everybody around me. So please, please, please look at the laboratory schedule. It takes 1 minute to shoot an email and put it on your calendar and confirm, okay? Because I don't want you to be turned at the door because there's too many people on campus, all right? And our laboratory, there's only like 3 of us, so we should be good. And again, if you can't make those dates, there'll be Saturday dates available, but I need to know about it. That's that for that announcement. Now, the second announcement is registration started this week. So please register for classes as soon as possible. If you guys are medical assisting, so I think it's your advisor is probably either Professor Jones or Dr. Nua. So if you don't know what classes to take, or if your classes aren't available, please get to them today. The quicker you register for classes, the quicker we can get the schedule solidified. Because if you do it late, it has financial aid repercussions, okay? And we'd like to avoid those. So 2 things. 1, make sure you got your laboratory schedule email out to me. And 2, make sure you register for classes. And if you know how to do that, go in your student self-service portal, right? You can type in on the top, portal.stratford.edu and your address, or you can go into student, here, this resources, and then click on self-service portal. Also, get a call out. You can even get an email out to me. I have instructions on how to do that as well. But I am the advisor for BS Health Science and nurses who are future nurses who want to transition from BS Health Science to the School of Nursing. And if you're interested in applying for the School of Nursing, give me a call so I can send you this YouTube video I made, and also some other documents on the requirements to getting into your School of Nursing. So what's for this week? I have chapter 46 notes. We are discussing, I think, microbiology and the microbiology lab. And again, like I stated today, it's going to be a short day today because I have to get to the laboratory and prepare for this afternoon. I mean, not this afternoon, for next week, because next week the laboratories start. But I think yours is like week 7 or 8. So what's due today? Everything that's due for week 4, of course, is due today. And so all intents and purposes, your midterm grade should be out by Saturday, midnight. And your midterm grade is essentially week 1 through week 4. But, you want to add some more points to boost it up a little bit. Try to do some week 5 stuff prior to midnight tomorrow, Saturday. But remember, your midterm grade isn't going to be on any transcript or anything like that. Your midterm grade is just simply where you are at midterm. Typically we have a midterm and a midterm laboratory, but since this is, like hybrid, I'm gonna pass for that so that you guys can concentrate on your other midterms. So essentially your midterm grade is any work that you submitted week 1 through week 4. So what's today? If you look at the chapter 46 notes, we're going to talk about quickly microbiology and disease. And essentially, we're going to talk about the clinical aspects of germ theory. And if you recall from your biology class and or your, what other class? Maybe medical terminology, talked about how pathogens, disease, they're everywhere, but you have to have a susceptible host, okay? And this particular chapter is apropos because of everything that's going around. Everyone is very, excited, of course, about COVID, but you also have to understand that any virus, it has to have a susceptible host. Where are my notes? Here you go. Let me expand that a little bit so we can read it. And then I'm going to be opening up the textbook. So we're going to be talking about the case. We always talk about the case. So hint, hint, that's what kind of your final written exam is going to look like. And your final practical examination, that'll be in the laboratories. We'll practice and we'll in the laboratory, and at the culmination of each laboratory session, where you have 2 of them, you get tested, and then and it's going to be based on those rubrics or those instructions, at the back of the chapters that show you step by step how things are going to go down. So this whole chapter, if you look at it, it's about infectious disease and how it spreads, and also a little bit about what does the laboratory do. And these tests that are in every department, culture and sensitivity, throat cultures, and gram stains. These are very, very common things, especially nowadays, because of COVID is tends to be a lower respiratory tract infection. So everybody who comes in with any upper or lower respiratory tract problems, we automatically have to rule out COVID, and then we have to rule out a whole bunch of other things as well. Okay, so that's pretty much the theme for today. And of course, you have homework here. Let me click on it, right? The best thing to do is you can either print this out or look in your textbook on where it is, and then just email the answers to me. And that's it. And do I want you? I don't want you to do the whole thing. I only want you to do the matching part here in 1 through 18, and the multiple choice part 1. So that's the multiple choice. The multiple choice part 1 through 15. Okay, that's it. 1 through 18 and 1 through 15. Okay. So with that being said, that's the homework. Email it to me, and of course do next week. And of course discussion 6, which is that we discussed in class. What is the difference between a screening test and a definitive test? Remember, at least 200 words, and you must have APA citation. And for those of you who are missing APA citations, I tagged a YouTube video on my reply to you. Please look at that, because it's not only good for this class, it's good for every other class that you have. Because remember, every time you submit something, especially if it's your own opinion, and you grab it from the interwebs or wherever you grab it from, it has to be a legit citation, and you have to document. Because you know what they say, if it isn't written down, if it isn't in the proper format, then it never existed. So let's jump to our textbook. So we'll go up to the top, then we go to our textbook, and we're going to go to chapter 46. Okay, internet is cooperating with me. Go up here, table of contents. To this day, I still don't know why they do it this way. Unit 6, I think. Nope. Unit 7. So you click on Unit 7, the little arrows here, and then you click on Chapter 46, Microbiology and Disease. So we look at the word microbio, right? Logi, study of micro, very small, bio, life. So that's what bacteria, fungus, and all of those things are. They're just living things. All they want to do is live. They're not bad things, nor they are good things. They're just things that either are growing in the wrong place or growing in out of control numbers. A classic example is E. coli. Escherichia coli grows, coli as its name suggests, it grows in your colon. It goes into your large intestine. It has a lot of really good purposes. Without E. coli, you cannot have vitamin K. You can't have a whole bunch of other covitamins that are required for you to live. But the problem is, if somebody at Wendy's went to the bathroom and did number 2 and then didn't wash their hands, now they have what? E. coli on their hands, and then they made you their sandwich. Then you eat that sandwich. Now what happens? E. coli is now in the wrong place. Then it'll grow because it's a living thing. So that E. coli now is on your lips and your mouth and your stomach, and that's why you get sick. So when you look at pathogens, patho, disease, gen, we already mentioned that you have to have a susceptible host. You also have to have a source, and it goes, when you think about microbiology, the source or the pathogen is in the wrong place and in the wrong numbers. Another classic example is a staph infection, Staphylococcus aureus. There is tons of Staph aureus all over your skin, all over it, okay? But the thing is, why don't you get staph infections all day? Because your skin is intact, it's good, and you're healthy, but you cut your skin and you don't wash the wound, you're gonna get a staph infection pretty darn quick. That infection then can go inside your arteries and veins and then give you sepsis. You'll probably be dead in about 6 hours. So you could see that Staphylococcus aureus, we have tons of it, but in the wrong place and in the wrong amount, like in your blood or inside your body where it doesn't belong, it causes trouble. It causes problems. So let's look at, briefly, Cindy Chen, she looks relatively young, maybe late 20s, early 30s, and she has a low CD4 count or T helper count. So I'm thinking right off the bat, we're thinking these 2 disease states, ATLV or she's HIV positive. Either way. So when you read your patient's chart, things like that, right, alert you to things. So 28-year-old, let's say she's a grad student, okay? And her chief complaint is sleep and nervousness. So you don't write the word insomnia or neuroses or major depressive disorder or anything like that, or a neurotic state. Her chief complaint is can't sleep, has to be in her own words, and I'm feeling nervous. So she arrives at the office, and several years ago, maybe more than a decade ago, she tested HIV positive, okay? So I have to look for intravenous drug use in the past, because is she still using things of that nature. I have to find what was the point source. How did she contract HIV in the first place? Okay, and again, not to judge her, but to know her story. Okay, and knowing her story will make you understand how we can protect her for any future pathology. So lives with her aunt, and of course, grad student, going to school. Oh, not a grad student. She's a phlebotomist. Now, side note, we do not care if you're HIV positive and you're in healthcare. We shouldn't care, and we don't. because there is something called universal precautions. Universal precautions assumes that everybody in the room, including yourself, are HIV positive, are hepatitis positive. So all the protocols that we have are to keep ourselves safe. So whether the practitioner, especially somebody who works with blood, is HIV positive or not, in the real world is inconsequential, because as long as the protocols exist, right? And you could look it up, but in my day, accidental stick was 1 in 273 chance of getting HIV. And I know this because when I was in EMS, me and my partner Julio wrestled an HIV positive man to the ground in our street clothes without gloves. We were rookies, we were very stupid, and I just remember the doctor telling me that, hey, you're okay. It's 1 in 273 chance that you're HIV positive. But for 9 months, we had to get tested. For almost a year, I had to take AZT and the AZT cocktail, and it was very, very scary. And I learned my lesson, right? If you're not trained to do something, don't do something, right? If you're not trained to wrestle a person with blood all over the face to the ground, do not do that. Leave it to the professionals. But me and Julio, we thought we were Batman and Robin. We thought we could save the day instead of thinking with our heads. What's the protocol? We were in street clothes. We weren't gloved up, and we are not in the business of taking down patients. But we were young and not so bright. Learned my lesson. So now she lost 20 pounds. Okay, maybe she's on a diet. But let's say her last visit was a couple of months ago. How do you know that weight loss is significant? First of all, if you're properly dieting and exercising every day, you should, if you're a 70-kilogram male, that's around 144 pounds, you should not lose more than like 1.2 to 1.5 pounds per week. Actually, that's a lot, or a pound a week. Now she lost 20 pounds, and you could see she's Asian, probably not that big of a frame, so that's significant, okay? And also, she has a persistent cough, sore throat for 3 months. So chronic cough, chronic sore throat. That's not good. So we did some blood tests, and then what happens? We did a T-cell test because she had her last T-cell count was a little bit on the low side, right? And then we want to see how well is her other medications holding up to her HIV, and then the throat culture because she had a sore throat. Now, let's talk about, we'll talk about what a culture and sensitivity is, but a culture, all intents and purposes, is I have to swab her throat and then put it in a proper growth medium, you know, those little Petri dishes and stuff like that. And then 3 to 5 days, it will start showing certain characteristics and colors and other physical attributes. And then that's how I can identify what pathogen is causing this sore throat. Okay, so this is your typical infectious patient. And again, goes, do we care whether she's HIV positive or not? Nope, because we have our universal precautions and we always assume every single patient is positive. So when we do her throat culture, we mask up just like everybody else. When we do her blood work, we do it just like everybody else because the universal precautions were designed to protect everybody, including our patient. So that's Cindy Chen, and that's some of the things that we should be considering. And again, today we have to cut a little bit short because I got to get the lab. So we now see how microorganisms, we have some examples, how microorganisms cause disease, how normal flora or normal things like Staphylococcus aureus and Escherichia coli or E. coli become disease. So microbiology is pretty important to us as clinicians. And here are some examples of some pathogens. Of course, we know bacteria. And if ever you had dysentery, oh, had it twice. Awful, awful stuff caused by these things called protozoans. You could get a fungus. Now, fungus, like Candida albicans, it's usually an immunocompromised patient. Candida albicans or candidiasis is very, very common post-op surgery stuff, and also patients who are on chronic meds. Helminths, I want you to think worms. Very, very common, especially pinworm, lower socioeconomic, and especially children. Prions are little bits and pieces of proteins, but very uncommon unless you eat brains. And that's where you get this Creutzfeldt-Jakob disease. If you watch, zombie movies and stuff like that, please don't eat any brains, because even if they're cooked very well, there's risk for this stuff. And that's also the reason why we don't eat human brains and humans, because of CJD. But let's talk about viruses a little bit more specifically. So viruses, they're ubiquitous, meaning to say is they can be anything. They could use DNA or they can use RNA. They're kind of like very, very, very small parasites. And they inject themselves into your nucleus, so they can go right through your cell wall. They can go right through the nuclear cell wall. So that's why they're very small. So let's say this is your size of a typical cell. 1 pixel on 1 dot is about the size of a virus. That's why at first I was very, very skeptical why we're all wearing masks, because it doesn't make any sense. But the masks are also, they're twofold. One, you want to decrease the amount of, because it's airborne spread, you decrease the amount of aerosol in the air, you decrease the amount of chances, and that's already proven. And number two, it also has a psychological effect. So everyone is conscious and aware that, hey, I should be aware of my breathing. I should be aware of who I'm breathing on. I should be aware of what am I touching. But just know that viruses are very, very small, because if they want to go inside you, they will, okay? And of course, they're acellular, they're not a cell. And the way we kill things, cells, because like bacteria, protozoans, a fungus, and even worms, they're floating around our body, and our immune system, quote unquote, sees it chemically, and it sees it, kills it, and attacks it. Well, the viruses, just imagine, if the virus goes inside this cell, I can't see it. The immune system cannot detect it, so it sits there. And that's why viruses, including corona, also known as SARS-2 or COVID-19, it can sit there up to 2 weeks inside of a cell. So it's kind of like a home invasion. All these horrible things are going on inside, and the police or the immune system has no idea that something horrible is happening until the viruses mass produce enough, and then they break out, and then they destroy the cell, and then they now migrate to a whole bunch of other cells. So that's why also viruses are very scary. And also the common cold, which is also part of the Coronaviridae family of viruses, it is very hard to combat. It's very hard to get a vaccine for it. And even though we have vaccines for other viruses, they're not 100% efficacious, or they don't work all the time. So this is why this pandemic was extra scary and extra frightening. Okay, and it's something to also consider. But remember, you need an immunocompromised host. So very, very young, and like infants. So should you be bringing your infant to the mall or the beach or the gym anytime soon? No, do not. Should you be bringing your 68-year-old grandfather who has a history of asthma and COPD? No, common sense, right? Very, very old, very, very young, have compromised immune system. Or with someone like me, I was a 12-pack year smoker, and I get chronic bronchitis like every other year. So I am also at considerable risk. So should I be going out and hanging out in large crowds anytime soon? I should not, right? So when knowing and understanding how a pathogen works, you can then adhere to protocols that will keep you safe. Now, classifications, they have the viruses and bacteria. They have their names, right? There's names and things for all of them. So eventually you're going to get to learn them. And definitely if you're going into further training, especially School of Nursing, your SCI 250 is microbiology. HIV, right? It is a blood-borne pathogen. Therefore, you can get it through, it has to be transmission of fluids, either sexual or through via blood and via needles. So why do we wear masks around HIV or even HTLV patients? Because remember, HIV patient goes, they, for all intents and purposes, they have no T cells, they have no immune, they have a very, very big gap in their immune system, so that common things like a cold or anything can severely affect our patient, and they get sick very, very fast. And the symptoms are broad, depending on you know, what stage they are in their illness. But there are certain things that are classic symptoms of HIV. And remember the difference between signs and symptoms. Symptoms is how the patient feels. It's more subjective, and signs are objective. Signs are things that they're an object. Like if we see a stop sign, we all know it's what? It's a big red sign. It's octagonal shape, and it says the word stop on it. So that's a sign. So when we look at this, like CNS complaints like depression and personality changes, I don't know, I wasn't there, so that's more of a symptom. But this stuff like tingling and numbness, again, I wasn't there. But if I see a rash, and a particular rash that's associated with KS or Kaposi sarcoma, which is a malignant fleshy tissue tumor, you have KS or Kaposi sarcoma, you're definitely HIV positive, because it only happens with HIV and AIDS patients. And again, the very, very big sign of a HIV or AIDS patient is the significant reduction of the T cell, also known as your CD4 plus count. Okay, and remember, they're very, very small. So we have medications to slow down the disease and to halt the disease, but we don't have anything that will stop it. But you could see a lot of people with HIV. I have a cousin who has HIV. He was diagnosed HIV positive more than 10 years ago. He's healthier than I am. But again, because he follows the protocols and lives with the virus. And here are just some other examples of viruses. Let me get to some other things because I got to wrap up next couple minutes. Let's look at bacteria. Now, bacteria, they're named on the way they're shaped. So if we look at this shape right here, they look like a bunch of rocks or a bunch of balls, and that's called coccus, right? So Staphylococcus will be a family of bunch of balls or cocci. The way I look at it, even if you look at the word coccus, COCCUS, doesn't look like a bunch of round balls. That's how I see it. Now B is bacillus or rods. So when you look at the microscope, they look like little rods. C look like a little spiral, spirillum, right? And these are all bacteria. And then of course D, they're like comma shaped or like sausage shaped. You see how they're like fatter and like more comma shaped than these rods. These rods are like much, much longer. And that's Vibrio. And here's the example. Vibrio cholerae is the bacteria that gets that you get if you get cholera. Now, read on this section here on what kind of dyes. There's gram positive and gram negative, and I will be also going through that in laboratory. And if we get a chance, we'll get to mess around with the stains in the laboratory. But in the laboratory, I'd like to focus more on the clinical stuff. But if we have time, we can mess with making gram positive, gram negative stains. It's like cooking. It's like a formula. You follow the steps, you know, and then you could look at it under a microscope. Now, because of these stains, either gram-positive, gram-negative, we can identify specific bacteria. Acid-fast or AFB, which is acid-fast bacilli, that's almost always tuberculosis. Every time you hear acid-fast or AFB, acid-fast stain, they're talking about, what do you call it? TB. Now, there's specific groups, but I want to get to this, the drug resistance microorganisms. Now, your antibiotics are funny. They're against biotic life. They're supposed to kill the bacteria. The problem is we already talked about that your body has other bacteria, normal flora. It needs bacteria to go on its processes. The classic example that we talked about earlier was Escherichia coli, also known as E. coli. Now, the problem is when you keep on giving a patient drugs that they don't need, right? Do you notice when you get broad spectrum antibiotics, the first thing you get is a stomach ache or a lot of abdominal cramping? Because guess what? That antibiotic that's killing the thing that's making you sick, it's also killing a whole bunch of other good things that your body needs. But again, it's the doctor's, give and take and weighing the benefits over the risks. So you having a tummy ache versus me getting rid of your pneumonia, it's a never-ending choice between the balance of what's best for my patient. But the problem is, most patients, when they come see me in the office, they want something, they want anything. And doctors are human just like anybody else. They want to keep that patient. And also, I've got to see as many patients as I possibly can so I can pay my bills and I can pay my nurses' bills and my medical assistants' bills and pay the rent and pay the lights. So a lot of doctors, and myself included, when I was practicing, I give in. So when the patient says, I tell them, it's viral, it should go away in 10 days. Oh, but I need something. So you give them something. You get, and they get upset if you give them a placebo, like fake pill, and then they get upset like I'm tricking them somehow. But even if it's viral, my patient wants an antibiotic. But when you look at it, if it's viral, especially if you're relatively healthy, most common colds or most viruses should go away in 10 to 14 days. You just have to, keep up your fluids and, stay at home and not go to work. Just pretty much palliative care, try to be healthy in the next 10 days and get as much rest as you possibly can. But many patients like, oh, my friend Suzette got amoxicillin 250 milligrams. Guess what I'm going to be giving my patient at the end of the day? So they can feel satisfied, so they can come back to my office and then spend more money. And you give in. But the problem is, the more antibiotics I give my patient, especially when I don't need it, you get multi-resistant drug strains. So you get bacteria, when they come back stronger. So the bacteria that you didn't kill, they come back stronger and they're out for revenge. So you get things like MRSA, VRSA, VRE, Visa, right? All of these, like for Staphylococcus aureus, right? Typically, I give oxacillin or methicillin, some form of penicillin. But if that doesn't work, you get MRSA. And then we give vancomycin. And then when that doesn't work, you get VRSA. And then we give you a very hardcore medication after that. During my training, MRSA and VRSA 20 years ago, relatively rare. Nowadays, it's on every ward and it's everywhere, okay? So take a look at this and read this, this part here regarding drug-resistant microorganisms. Very interesting. Here's don't have to memorize this, but it's nice to look through it, set of diseases. But we now know how disease works and how things get in. Now I'm going to jump right to, since I'm kind of running out of time, fungus, parasites. I'm going to, there's worms. If you want to look at that. Remember helminths, worms, but we have medication for that, anti-helminthic medication. They get rid of those, but still, it's just gives me the creeps. So if we look at how we diagnose or how we look at infections, of course, I have to take a history, I have to take a physical examination, and then remember your SOAP. This is my subjective. Then I have to do some labs, right? That's your objective, right? Now I have to look at the specimen, okay? And then I send it off to the lab, and I could do something called a CNS. That is a culture and sensitivity. Okay. Okay, here you go. Now, one part of the test, if you see this, this is a growth medium in a Petri dish. It's usually like some kind of gel stuff, and it could be like made out of chocolate or made out of blood, right? And then this gel stuff is called an agar, AGAR. Now, do you see how the bacteria grows, and it grows in a certain way and a certain color, right? Well, that's called morphology, or the study of its shape. And sometimes it has different colors and things of that matter. So that's the culture part. You grew something, and you can identify it via microscope, or you can identify it via how it grew on the culture. Now, that's culture. Now, the sensitivity part is this, okay? All these little discs are antibiotics, okay? Let's say this is antibiotic A, this is antibiotic B, and this is antibiotic C. Those are my choices for my patient. Now, which one would you take that cleared the most bacteria? This one didn't do anything. C didn't do anything. A had some, but look at B. Ooh, and look at this one, even better. Look at these, even better. So that's how the doctors, in theory, should be really choosing your meds, okay? You have to do a CNS. But many times, for expediency, I want to see as many patients as I can. We do what is called empirical therapy. And empirical therapy, I look at your history and I'm like, and we take a best guess. And if it works, you're well, thank you. But if it doesn't work, you come back next week and I give you another set of meds. That kind of medicine has to go away. But again, because of business, because of trying to see as many patients as you possibly can, there's still a lot of doctors who do that foolishness. And I have to admit, I kind of did it myself. But me, I'll take a CNS while you're taking that empirical medication. So if it doesn't work, I already now know what does work, okay? And this is a CNS, a culture and sensitivity, okay? And then we monitor and see if it works. And if it doesn't work, we start back from the very beginning. Here is a blood agar, right? And this is how we do my patient had a wound here, and I want to see if there any bacteria. I could do also a CNS here. We could also send it to the laboratory so we can look at it, or we could look at it ourselves. We swab it in here. We put some stain on it, right? Remember the gram stain? And then look at it in a microscope. Now remember, this test, CNS, takes anywhere from 5 to 9 days. So it takes a little bit of time. Same thing with the HIV. It's, I believe the current is Western blot technology. That's why I'm also very, very skeptical regarding COVID testing. There isn't a single article, and I know of no physician. And I worked in New York City for 6 years, so I called everybody in the last 4 months. No one knows what's in those tests. So that should beg the question, what's inside the tests? How do you know the tests work? How do you know if they're real or not? Okay. And some of the numbers don't seem right to me, which, by the way, I've been teaching epidemiology for 10 years, and it's making little to no sense to me. So always look at data, always be skeptical, especially anything from mass media. I don't even watch mass media anymore because unless I want to be entertained. Sputum is not just spitting into a cup. You got to have your patient, really get down there and really, really cough up something good. Wound, of course, and stool. And remember, utilize all your universal precautions when you're dealing with all this. And we'll show you in lab what some of these kits look like. And in lab, if you want, oh, actually not if you want, we actually are going to play around with urine and how to deal with urine specimens as well. So I think I went a little bit over time, but I think, and read up a little bit on potassium hydroxide mounts. That's usually for fungi or funguses. Fungi is the proper way to say funguses. Culture media, already talked about that. And this is swabbing. You'll do this in microbiology, and you could see how, depending on what culture media, you can look at what grows here, right? Here's some patterns and how to, and this is a wire loop. That's what we take. We heat this wire loop so it's sterile, and then we swab whatever our sample is, and that's how you plate. And in microbiology, you got to do that stuff. Now, this is the thing that I wanted to show you guys, and we're going to play around in laboratory. Read over these procedures at the end of your chapter, because these are the things we're going to be talking about in laboratory. We even have strep tests that we could play with. And we have also microbiology equipment as well, if you want to play with that. And how to create the smear. And also, I believe they also have, maybe if not this chapter, they have how to prepare a, what do you call that? Gram stain. So my apologies for going lightning fast, but you can always pause the video. So what's due today? All week 4 items. What's due next week? Week 5 items. There is no midterm for this particular course, but there is a final at week 10, and it's take home. And please register this week, and please get that email to me to confirm that you are coming to the laboratory, and the laboratory dates are in your announcements. If there are no questions, any questions? If not, thank you very much, and I'll see you next week.